All right, welcome everyone. It's 8:30 on my clock, so we're going to dive in. I can't wait to get started with this one. You are here for the AMSSM Fellows Online Lecture Series, and we are very excited tonight to have Dr. Matt Silvis to speak to us about running gait analysis and gait retraining. Again, this is the National Fellows Online Lecture Series, which is a subcommittee sponsored by the AMSSM Education Committee, also co-sponsored by the Fellowship Committee. And tonight we are hosting our next installment of our weekly lecture. And as again, we'll be talking about clinical running gait analysis and hearing from the wealth of background of Dr. Matt Silvis from Penn State University. More on him in just a minute. Before we dive into that, next week, on Wednesday at the same time, same place, we will be hearing from Dr. Kent Deduck on gastrointestinal disorders in athletes. Again, that's next week, Wednesday, and that'll be another lecture just like this, a very important topic that there will be questions on the boards, fellows, so a good one to dial into. A little bit of housekeeping before we get started. This online lecture series was developed to serve as an adjunct to your individual program's educational curriculum, not to replace it. So you're here to get kind of the icing on the cake and to allow you to have access to nationwide and even worldwide subject matter experts in a variety of formats. So hopefully this is a useful tool for you as fellows as you prepare for your CAQ exams. And honestly, for a lot of us sports med docs across the country, maybe even the world, who are recertifying and trying to stay current on our skills. So very good stuff. As a couple of ground rules, please do keep your device's microphone muted, keep your video camera off. We will be, listening to our lecturer throughout the lecture. And if you do have questions, please submit those through the chat function in Zoom. And include your name in your program if you wish. At the end of the discussion, I will be feeding those questions to the speaker, and we will go through those at the end of the program. There will be a speaker feedback form at the end of this lecture. Those are very valuable, and so we really do ask you to complete that. It just takes a minute. It's a link that you click on, and it'll take you through just a couple of questions, and we do value your feedback. So we'd appreciate if you could give back to us and give us some feedback. Without further ado, Dr. Matt Silvis, I'm very excited to have him on our lecture series tonight. I've been looking forward to this one. Matt is a graduate of Penn State University College of Medicine in 2002. He then went on to complete a family medicine residency at Wake Forest University in Winston-Salem, North Carolina. After residency, Dr. Silvis went on to practice wilderness medicine. I'd love to hear about this, Matt, at some point. Practicing wilderness medicine in rural Wyoming before returning to Wake Forest, where he did a sports fellowship. And he's currently serving as a professor in the departments of family and community medicine, as well as the Department of Orthopedics and Rehabilitation out at Penn State. He is the Division Chief of Primary Care Sports Medicine. He serves as the Vice Chair of Clinical Operations for the Department of Family and Community Medicine. He's the Director of Adult Ambulatory Care at Penn State Health, serves as a team physician for the Hershey Bears Hockey Club and the Hershey High School. He has special interests in endurance athletes, as well as exercise, concussion, and I'm sure many other things. This is just a quick synopsis of Matt Silvis. And we look forward very much to hearing his comments. My name is Nate Nye. I'm an assistant program director here at the military's Sports Medicine Fellowship Program in the DC area. And I have the privilege of working here with many great colleagues and training our fellows for the military. So without further ado, I am going to unshare my screen and turn it over to Matt.
Thanks, Nate. All right, let's bring this up. Can you guys see that okay?
Sure can, Matt.
All right, thank you. Well, thanks for having us. Thanks for joining us on a Wednesday night. I know it's hump day and probably people are pretty tired here Wednesday evening. So hopefully the next 45 minutes will be helpful, especially for our soon to be newly graduated fellows as you start your clinical practices. This is an area near and dear to my heart. And I hope that everybody will get some real practical information out of tonight's lecture. Learning objectives for tonight's talk, we're going to actually talk about key features of a two-dimensional clinical running gait analysis. This is something that we do here at Penn State, and I'll explain our philosophy around this analysis and why we feel strongly that this is something that anybody in sports medicine should be able to do in their clinical practice. We're going to talk about how we use this gait analysis to work with injured athletes and how we can guide our rehab of athletes through this analysis as well. So there's no disclosures today. So just start off by just saying that running's very popular in 2022. Running did not become a popular form of exercise until the late 1960s. And there was a book published called Aerobics, which was the first time really in US history that running was advocated as a form of exercise. Frank Shorter won the marathon in 1972 at the Olympic Games in Munich. And then there was this book by Jim Fixx. I have a copy of this in my office called The Complete Book of Running. This is kind of like the first runner's world that was published. And running as a sport and running as a form of exercise really became popularized by these three kind of within a decade developments in the United States. Today, running is super popular. You can see the statistics. A lot of runners run yearly in the United States. There's a lot of runners that are participating in all sorts of different running activities, from couch to 5Ks to ultra marathons. Running is a very valuable way to exercise. At AMSSM, we're all about exercise as medicine, and running is a wonderful way to increase the likelihood that you'll live and age well and decrease your risk of developing chronic conditions or treat conditions that you already afflicted with. So running is a very powerful, we call it a polypill. It really has a lot of benefits for human health. There's also been more recently a rise in the ultra marathon distance, which is any foot race greater than the standard marathon. And this is just a reminder that people are pushing and pushing and pushing the boundaries of what it means to be a runner. I love this picture on the right, on the top. This is the Badwater Marathon in Death Valley. The runners literally have to run on road paint so that their shoes don't actually melt during this race. Tells you a little bit about the mentality of an ultra marathon runner and how hard they work to complete these events. There's also been a change in the runner demographics. So as participation grows across society, there are folks that are running now that don't fit the typical runner profile that we think of historically. So there's higher body masses, less training, generalized decreased athleticism, all sorts of different pieces as people adopt running as a form of exercise. This is quite noticeable in these two videos. The first video is a picture of the New York City Marathon at the halfway distance. And you can see this is at this point in the race, the #1 male runner. And you can see that his running form is duplicated by everybody that follows him. As this pack that's chasing him comes across the camera, you can see that they're all just this effortless bounce with their running. They look like they're overstriding, but they're actually not. Their feet land beneath their bodies. It's just beautiful running. And every runner in this video is running with the exact same motion. This is a much more normal experience. This is my personal life as a runner. I'm not an elite runner. This is the start of the Marine Corps Marathon in Washington, D.C. All sorts of runners, all sorts of running forms are represented at the start of this race and throughout the course of this marathon. This is what taking care of recreational runners is in your practice. You might have a few elite runners that you care for, but the majority of your practice when you care for runners will be your recreational runners at various levels of competition or non-competitive running just for exercise. So why do we use running gait analysis? So over 60% of running related injuries are related to training errors. So the most important thing you do when a runner's sitting in front of you is really get at their history. The history will tell you a lot. Whenever you do your examination, it's often site specific. They hurt on their tibia, you push on your tibia, and your differential starts to build around that differential. Most runners already think they know the diagnosis when they come in your door. And really trying to break down why they ended up with this running related injury is so critical. My area of professional interest is when it's not a training error. And then we start thinking about, is it a failure of biology? Do they have disordered eating, for instance, where they're just not consuming enough calories to match their caloric expenditure? That's a failure of biology. Or is it within their biomechanics? That runner who has their third stress fracture on the right side of their body, why is that happening? And that, to me, is where running gait analysis can be a really powerful tool in your chest to evaluate that runner and take their evaluation ultimate management to the next level. Why do we use video gait analysis? The stance phase of running, meaning feet on the ground, 0.2 seconds, very, very brief. That's quicker than the human eye can see. The human eye can see about 16 frames per second, a digital camera up in the neighborhood of 1,000 frames per second. So the power that you get with video technology, even on your smartphone in 2022, is just phenomenal at being able to break down gait. It can be a teaching tool. You can use this gait analysis to teach your runners what might be predisposing to their injury and how they might change their running form to address that underlying risk. You can view their mechanics before and after an intervention. And if you want to have runners in your practice, marketing that you're interested in, you perform gait analysis can be a boon to really drive runners in through your doors so that you become your local community running expert. It is not this. This is a running lab in a shoe store. This is when you hop up on a treadmill, someone tells you that you're pronating too much, you stand on a plate, and the indentation you leave in the plate tells you something about the shoe you should buy. This is not based on science. This is really marketing and almost gimmick related. This is not what I mean by a video gait analysis. And you'll see through some of our videos that we're about to show you in our process how different an actual clinical running gait analysis by a sports medicine professional, how much different that is. The gait cycle. When we refer to a runner, we're talking about someone running less than 7 minutes per mile. A jogger is somewhere between 7 and just under 15 minutes per mile, and a walker is somebody between 15 to 30 minutes per mile. A gait cycle is the period of time from initial contact of one foot to the initial contact of the same foot. And you can see as you move across walking, jogging, and running that you spend less and less time in stance and more time in the air. And that's what we think of runner. You want to minimize your contact with the ground. Just a couple simple definitions. The most important one I'm going to mention today is cadence. That's kind of your step rate. How many times do your feet hit the ground per minute? It's thought, and there's some debate around this, that we should be around 180 steps per minute. And that's kind of considered to be normal. Cadence is something we're going to talk about today in detail as we kind of go through our approach to gait analysis. The other key feature from a definition perspective is really stride length. The distance between two successive placements of the same foot. It's consistent of two step lengths, which is that distance between one foot hitting the ground and the next foot making initial contact. Most runners run with a width of about 4 inches between their heels when they're walking. That decreases that distance while they increase their running speed. We're going to show you today in the gait analysis, whenever it's too much, they cross midline. And we're going to talk about why that's related to certain problems like miserable malalignment, how you can key in on that during your gait analysis. And then there's out-toeing. We're going to talk about out-toeing today as well and how you can pick that up on a video and how that could actually, that out-toeing that might be causing shin pain, the problem really is in the hip and how you can get to that through a gait analysis. So it's important to remember that everybody brings their own running gait to the table. This is not for performance. There is really no data out there that one way of running is best to deliver a high level performance. I'm old enough that whenever I was running track in college, my idol was Michael Johnson. Some of you in my age category will remember Michael Johnson as an international Olympic and world record holder in the 400-meter dash. Michael Johnson ran with an arched back and a neck that was extended backwards. And people used to make fun of his running gait until he won world records and Olympic medals. And then everybody wanted to duplicate how Michael Johnson ran. It just goes to show you how people kind of swing with different types of running movements for performance reasons. There really is no one size fits all though. So remember, we're doing this gait analysis for people that have recurrent injuries, trying to figure out why are they recurrently injured. Is it an asymmetrical movement? Is it an abnormal movement pattern, such as valgus collapse or their foot placement? Is it abnormal motions? We're trying to get to the reason why they're having this injury, not for performance, but to minimize re-injury risk. We want to schedule these runners not while they're hurt. So a cardinal rule for me is they need to be through rehab. They need to be actually running again. They need to be able to do a long, slow distance. That's kind of our goal when they're on the treadmill. And they need to do that without feeling pain, because that will change the way they move. And now we're videotaping a compensated gait pattern, which is not how we want to make changes. We want them to look as much as possible inside how they would look when they're running on their own. So a couple of questions we ask at intake: do you normally use a treadmill? If they're a novice to a treadmill, it may take a little bit longer for them to acclimate to it. They may need to practice on one before they come in for their gait analysis. Are you comfortable using a treadmill? When was the last time you jogged, walked, ran? Step length is commonly reduced on a treadmill. There's nothing we can do about that. That's just one of the factors. It's a limitation. The treadmill deck, you need to have a stiff running deck. You need to have a powerful motor. So you really need to have a high quality treadmill to run, especially a more elite runner. Otherwise, they'll feel like their foot, when they hit the belt, they'll feel like it's slipping. And that's not going to lead to a good gait analysis. You have to have a kind of an industrial grade treadmill to perform this analysis. We use a simple tripod with an iPad. So you don't need to spend gobs of money on sophisticated equipment to do a clinically relevant gait analysis. We do 2 views at a right angle to each other. We film from the side, or a sagittal view, and we film from behind, which is actually called a frontal view. So we film from behind the runner, which is a frontal view, and we film from the side of the runner, which is called a sagittal view. You can zoom in and out. You want a reproducible camera location with fixed views, and you need to practice and practice and practice. Experience improves reliability. I am way better at doing this now in my career than when I first started. And I work with a physical therapist here at Penn State who shares my interest in this. And we have learned collectively a lot together. And that really has formed the basis for what I'm going to show you tonight. You can use skin markers. I put in blue on the slide today where those skin markers are classically placed on a runner. You don't have to buy fancy, expensive, retro reflective tape-based markers. You can use any brightly colored tape. It doesn't matter. You want to apply to skin, or at least a tight clothing. That's really important for research, which we're going to talk about at the end of the talk today, but not critical if you're doing this in your office. We have tried different video motion technology. These are 3 that we worked with here at Penn State: Dartfish, Huddle, and Canovia. Remember, I don't have any disclosures today. We have experimented with all 3. I think when you buy sophisticated running gait analysis equipment, you can get thousands and thousands of data points back. That is not going to help you. You're going to drown in that data. So we use this technology to follow our algorithm, which was what I'm going to show you tonight. Clinically relevant running gait analysis. That's what this is about. What is relevant clinically? What data points are important to collect so that you can eliminate the noise from the valuable pieces of this analysis? Treadmill running normalizes within 6 to 10 minutes and approximates a well over ground running. And we're going to talk a little bit about that at the end of today's talk based on some research that we're publishing here at Penn State. Again, you want them symptom-free, and they should run at their long run pace. It's not at the time for them to sprint in the treadmill. You want the long run pace. These are some validated variables that can be looked at when you're performing a running gait analysis, again, from the frontal and sagittal plane. There are Kappa statistics. This just tells you how much people agree with a reading when they're different individuals reading, and then how much they agree with themselves. That's inter and intra-rater reliability. And I'm going to come back to this point at the end of the talk today when we talk about a research project that we recently completed on this. So this is a kind of a normal sagittal view of a runner on our treadmill in clinic. These are some of the things that we're looking at from the side view, and I'm going to take us a walk through the most important features of our clinical gait analysis. But this is a very simple, again, tripod, iPad, good treadmill. You can see we can put them into slow motion, and then we ultimately can break this down into still frame. This is the view from the back of this runner. Remember, the back, the posterior view is called the frontal plane. So that gets a little confusing in the semantics of tonight. And you can see, again, a variety of factors. And I'm going to take us a walk through the most critical variables in today's talk here. But this is, again, an example of what this looks like from behind. We also will frequently run our runners barefoot while they're in clinic in both views. The reason for barefoot running is we want to see them running in their shoe. If they're using an insert and orthotic, we'll refilm them in their insert or orthotic, and then we'll have them run barefoot. We get an assessment of how do their biomechanics change between those different states, and do they feel better running in those different states? Take off your shoes, you're less likely to hit your heel. Does running up on your forefoot or your midfoot take away some of that tibial pain that you've been experiencing, or patellofemoral pain? Do they feel better whenever they're running barefoot? That's a question that we can answer through this analysis. This is a runner who has miserable malalignment, and you will all be able to identify this very easily as we go through our metrics, but you can see she has knock knees or valgus collapse of her knees. She hyperpronates at the ankle and feet. This is oftentimes coming from hip abductor weakness, external rotator tightness. That can be a problem, and that can lead somebody to head down into this miserable malalignment. And this is what that looks like. And we'll talk more about that as we kind of go through our still frames and our analysis today. And this is that same runner. Every once in a while, we'll film from the front, and you can really see with this frontal view, and this was highly illustrative to the patient, even more so than the frontal view or the posterior aspect of our filming, that she was running with her knees collapsing. And that's a sign of weakness in the hips. So I'm just going to present one key paper before we go through our analysis. Overstriding is really a bad thing for runners. Overstriding leads to heel striking, where you're landing with your foot in front of your center of mass, in front of your body. Those runners in that New York City video clip, they look like they're leaping with their running, but their foot's actually landing directly below their body, their center of mass. They're not hitting their foot well in front of their body. We call that overstriding. And overstriding is related to tibial stress fractures, medial tibial stress syndrome, patellofemoral pain, common stuff in runners. Again, you can rear foot strike every day that you run. If you're not hurt, there is no reason to change that. But if you have certain injury patterns, like I just mentioned, and you're a rear foot striker, a lot of it's around overstriding. So a lot of what we're picking up on these videos is to correct that overstriding. This is a study that was done out of Kenya. This is really the basis of the book, Born to Run, which is about barefoot or minimalist running. And really this highlights the idea that you get an impact force that gets sent up your heel to your shin bone, to the front of your knee, which greatly increases your risk of an injury, and can be modified if you change to a midfoot or a forefoot strike. And so we're going to kind of go through that, and you're going to see how we start building a case that overstriding may be bad for this runner. But remember, not for performance, not to correct somebody that's not hurt. It's okay to rear foot strike if you're not hurt. It's only if you have certain injury patterns that this might be applicable. So here's our evaluation. I'm going to walk us through these different variables again, sagittal and frontal planes. And we're going to start with the sagittal plane. Just a reminder, sagittal from the side. So the first thing we're going to look at is initial contact, and we're going to look at how they foot strike. American runners, 85% of us rear foot strike. That's being demonstrated in letter C, 10% midfoot strike in B, and forefoot strike in A. It's important to identify when you actually have initial contact. Initial contact is being demonstrated in B. This is when the foot has struck the ground, but the shoe has not deformed. So it's kind of in that span that we're looking at initial contact. It's not when the foot is still slightly in the air before they hit the ground. Now that may seem like you're teasing hair on that, kind of, But that's kind of what we mean by initial contact. Foot hitting the ground before you get shoe deformation, which is what's being the difference between B and C in this image. Here's an example of someone who's a heel striker. You can see that she's striking the heel right before she actually starts to deform the heel of her shoe. Here's an example of someone who is a forefoot striker, landing on the front of their foot. So this is something that's relatively easy to identify on your gait analysis. Then we have foot inclination at foot strike. This really is how much dorsiflexion does that runner have when they strike the ground. You can imagine if you're a heel striker, a rear foot striker, you're going to have a higher degree of inclination at foot strike than if you're a midfoot or a forefoot striker. Well, ankle dorsiflexion, that foot inclination at foot strike, is associated with higher peak knee extensor moments, which is linked to patellofemoral pain, increased knee energy absorption, linked to patellofemoral pain, higher peak vertical ground reaction forces linked to patellofemoral pain, tibial stress fractures, and shin splints, and a greater braking impulse, similar. So while this in isolation by itself may not be a problem, it could be part of a greater picture that they're rear foot striking. And if they have the right injury history, you might want to get this runner up onto a forefoot or midfoot strike. Tibial inclination initial contact. This is measuring the midline of the lower leg relative to true vertical. So you can see in this runner, here's the midline of the lower leg. True vertical is dropping a plumb line straight down. You can see that she's inclined from where she's hitting. She's a rear foot striker. She's reaching out across her body. B is ideal. B is directly straight down. So that is kind of the ideal scenario. This person, you could be building a case that they're overstriding with their running. An extended tibia is not ideal in a runner with impact-related injuries, and increased inclinations associated with bone stress injuries to the lower leg. So again, it starts to build a case for why that runner may be getting these recurrent injuries. Heel to center of mass, same stuff. So you can see you just drop this plumb line down from the center of the person's mass, and then you measure forward to where the heel is striking. She's running and she's striking her heel ahead of her center of mass. This runner is not. This is actually our second fellow here at Penn State. He's a forefoot striker, and you can see that he's actually striking beneath his center of mass, and that's a more ideal way to run. Again, if you're having certain injury patterns. We have rear foot strikers. This is a knee flexion angle at initial contact. Again, all these images so far are when the foot hits the ground before shoe deformation. That's all these different variables you're measuring in one still frame. So this is a rear foot striker, and this is a forefoot striker, and this is the calculation at the knee for this knee flexion angle. Ideal is, and normal is 20 degrees. This runner, you can see, is measuring around 24 degrees. So she's past that point. So she's not getting as much knee flexion, which helps absorb the ground whenever you're striking it repetitively over these runs. She's running with her tibia extended more, and that could mean that those impact forces are not being absorbed as naturally as they could be, or as ideal as they could be. And some tissue could be experiencing the brunt of those forces, leading to a recurrent injury pattern. Here's knee flexion angle at initial contact. This is an excessive decrease. You can see in this runner and this runner, they're not getting enough of that knee flexion to absorb that impact because they're extended too far ahead of their center of mass. So this all these different ways are really driving at overstriding. So long strides are not the issue. Those runners in that New York City video at the beginning today, they all look like they have long strides, and they do. However, they're not overstriding. Their foot is underneath the center of mass whenever they strike the ground. That's because they have appropriate hip flexion. It's probably related to their cadence, how many steps they're taking per minute. All these different factors actually allow for a runner to strike with their foot below their center of mass. That can dampen impact forces and ultimately impact recurrent injury risk. This is a measurement of knee flexion angle at mid stance. At mid stance, you should be at 40 to 45 degrees. If you're less than 40 degrees, that reduces shock absorption. It's been related to patellofemoral pain and tibial stress fractures. If you have greater amounts of knee flexion, that's associated with patellofemoral joint pain. So greater than 45 degrees, shown in B, is a problem because now it's almost like you're landing in a squatting position because you're beyond that 45 degrees. And we know that deep squats and lunges can cause patellofemoral pain. What's no different than a runner who's having anterior knee pain. So too little or too much knee flexion at mid stance is a problem. Here's examples of what this looks like. We have normal on the left, and we have an excessive increase on the right in a patient with anterior knee pain recurrently with running. So her issue is this excessive increase of her knee flexion angle, which is something that we can target through rehabilitation and gait retraining. We also have ankle dorsiflexion at mid stance. This is the midline of the lower leg relative to the sole of the foot. The normal is 20 degrees. The knee should be directly over the toes. If you have an increased inclination, it's related to Achilles symptoms. So that makes sense. If you have more inclination, you're going to put more stress and strain on that Achilles structure, and that can be a problem in, again, a certain set of runners. Last on the sagittal view is going to be your trunk lean. This is how much forward you're bending or how much straight up you are. There's very little attention to scientific literature on trunk lean. It's popular to talk about these in magazines like Runner's World, and there's been a variety of different types of running that's been advocated to address trunk lean, like chai or key running, pose running, the barefoot running. So we know that a small increase in trunk lean can result in significantly lowering stress across the patellofemoral joint without increasing stress at the ankle. So there's an idea that you want to have a slight trunk lean, but you don't want to have too much of a trunk lean because that can actually cause some problems as well. And you don't want to run backwards because that can create lumbopelvic pain. So here's some examples of trunk lean. The woman on the left has an appropriate trunk lean. The two runners on the right are excessively bent forward, which can cause a different sets of issues. And so trunk lean sometimes is applicable in a runner because, again, if you're out logging large amounts of distances over a week, all these biomechanical changes are magnified over many, many miles, many, many steps, and that can accrue and create different types of soft tissue injuries. Vertical displacement in mass is basically how much you head bob when you run. That's an inefficient way to run. And we know that it's related to ground reaction forces, knee extensor moments, and braking impulses. This is an easy thing to correct by increasing someone's cadence, which we'll talk about in a little bit. And then last, hip extension. This is a controversial area in gait analysis. People don't really know what to make out of hip extension. It's not a variable that we adjust very, very often here at Penn State, but we do know that if you have reduced hip extension, it causes increased lumbar spine extension, bounding, increased overstriding, and increased cadence. So different things can happen if you don't have the correct amount of hip extension. How much those are implicated in running injuries, that's still an area that's been under-researched. Here's an example of one of our patients as we're measuring her hip extension. I'm going to switch over briefly to the frontal plane. Remember, the frontal plane is the posterior view of the runner. From posteriorly, we only look at a couple of variables. One is we look at lateral pelvic tilt. That's how much tilt there is in the pelvis. You can see males and females, 3 to 5 degrees is normal for a male, 5 to 7 degrees for a female. We're in the normal range here. We're outside of the normal range here. Reminder, whenever you have someone in a gait analysis, you want them to wear contrasting clothes. The woman on the right, this is not an ideal outfit to do a gait analysis. This is my fault for not informing the patient to make sure that her top and her bottoms aren't a direct match so that we can actually analyze the gait correctly. Knee center position, this is at mid stance. You should be able to drop, again, a line that connects the hip, knee, and ankle in a straight line. If you can see here, this is excessive medial on the left. That tells me that she probably has weak hip abductors. This is a marker of miserable malalignment. And this is something you can pick up on this knee center position from the frontal view. And foot center of mass, again, this is the medial lateral distance of the medial heel to the vertical line from the center of the sacrum. So you can see as you drop this line from the center of the sacrum down to the medial heel, there should be a straight line. Too little or too much can be a sign that someone doesn't have appropriate, in particular, hip muscle strength and or flexibility. Another measurement as knee separation. you should be able to do what we call the flashlight test. You should be able to shine a light from behind and see that light if you're standing in front of the runner. You should be able to see that flashlight shining through. There should be space. If there's not, like in these two runners, that's a sign that they're crossing over. So remember at the beginning of the talk, we talked about step width and how that decreases with running speed. Well, it can decrease as well because you have miserable malalignment, which is pretty common, especially in teenage female runners here on the right. And so this is something that we can actually have a pretty significant impact on through rehabilitation. We also look at foot position, rear foot and forefoot position. The position of the rear foot and the forefoot is associated with different injuries depending on whether you're positioning correctly rear foot or forefoot. Increased supination, that pes cavus foot types associated with bone stress injuries. Increased adductions related to bone stress injuries. I just highlighted in blue again today how these are clinically relevant for runners whenever you're doing your gait analysis. Remember, the focus of this running gait analysis is on clinical relevance, not just tons of data, but what is clinically relevant data that you can act upon as a sports medicine professional. Heel eversion. This is a really important metric that we measure. This is the rate of pronation. How fast does it take someone to go from kind of a lateral heel strike to pronation? If it happens within one frame on our iPad with our video technology, that tells me that they're pronating excessively quick. That's usually a sign of posterior tibialis tendon weakness or insufficiency. You're not controlling the rate of pronation, and that can put excessive amounts of strain on the posterior medial tibia, which is where we see medial tibial stress syndrome and commonly tibial stress fractures. So rate of pronation, that heel eversion rate of pronation is a really important metric that we look at. And then heel whips. A lot of people whip. This is another variable that there's not a lot of known sequela of this. This is pretty common to see, but we do see this in runners. And again, heel whips oftentimes are related to hip-related issues in runners. And then here to kind of finish up this section, this is the foot progression angle at mid-stance. We look at toe in or toe out. If you have toe out, which is being visualized here, that could be a sign that you have tight hip external rotators. If you have toe in, which is being demonstrated here, that's associated with hip internal rotation, knee internal rotation, ankle internal rotation, or some combination of all three, kind of puts you in that miserable malalignment positioning. Other things we look at, we listen to the runners. If runners are hitting the deck of the treadmill loudly, they're a loud heel striker. That could be related to excessive impact forces and why they're in your clinic repetitively with stress injuries. If they're shaking the treadmill, we've had that happen too. I can actually literally tell a runner, do you hear yourself hitting this treadmill? Stop making that sound. And immediately they'll make an adjustment. They run up on their forefoot, midfoot, and they increase their step count, their cadence right away naturally, just because I'm giving them feedback to run softly, run more quietly. We can manipulate their cadence, which is that step rate. We know that if you increase by about 10%, it actually takes you from an overstrider to a normal strider. And that can make a difference in a runner who's suffering with repetitive running related injuries, as I've already articulated. 180 may not be the magic number, but if their cadence is 140 and you increase by 10%, you get them up to 154. That's something you can actually work with the runner and you can make significant changes. And I've seen that just a tremendous amount in my career working with runners. This is what our sheet looks like. We have a simple sheet in our clinic where we literally go through the video. We can do this video analysis now in just a couple minutes because we do these a few a month on a regular basis. It doesn't take long once you kind of get used to it. And you can see we just kind of march through. This is the frontal pain measurements. These are the sagittal plane measurements that we do. And we just have this available, and we do this in our sports PT clinic. Myself and our sports physical therapists collaborate on these gait analyses. So what do we do with this information? We can make gait modifications. We could convert to barefoot or minimalist running. We could change and provide that runner with orthotics or inserts. We may need PT to address deficiencies such as heat weakness, loss of mobility, flexibility. We may need to adjust a training regimen. There's lots of potential outcomes. This is highly individualized what you do with the information, but gait analysis gives you a lot of information that you can work with. Not everybody's equipped to have that kind of a treadmill, the time, the technology, the expertise to do this. We can benefit from wearable technologies. We have this in our office called Runscribes. These are literally detect sensors that you can put in the back of the shoe. You can send a runner out of your clinic. They do a run, they come back in, it downloads to your computer system, and it tells you where they strike. It tells you what their contact time is, their impact forces, all sorts of data. So Runscribes are something that we're increasingly utilizing here, leveraging this technology in effort to have runners run in their real world environment and not artificially on a treadmill. There's a new wearable, the Dorsiflexion, which I was just checking out online a few days ago. This provides similar information to the Runscribe, but again, a lot of these wearables are coming out, and I believe there was just an article published not long ago. It was either in British Journal of Sports Medicine, I think that, or Current Sports Medicine Reports, talking about wearable technology and biomechanics, and there's a good market for this out there. So some clinical pearls before we talk briefly at the end today about our research. The three best measurements, in my opinion, when you're doing 2D gait analysis for knee force, if you have someone with patellofemoral pain, for instance, is foot inclination, initial contact, peak knee angle at mid stance, and step rate. That step rate, really easy to modify and manipulate. They actually have a metronome app you can download to your smartphone. If you don't want to hear dit, 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 dit while you're running, they actually have metronome apps set to music. So the beat of the music drives your cadence. That's a great way to engage a runner, especially a younger runner, in making these modifications. So these are some of those clinical pearls that have come out of my experience in doing running gait analysis now for quite a number of years. So I'm going to have Lindsay Lafferty join us now here at the very end, just to talk a little bit about research that we've just now kind of hot off the press stuff here at Penn State. Lindsay, you want to go ahead and take over?
Sure. Thanks. Thanks for inviting me to talk about our research that's going on at Penn State. So if you want to advance to the next one. So traditionally, like we've been talking about, Dr. Silvis has been talking about this entire talk, running gait analysis has occurred indoors on a treadmill, but whether treadmill running approximates overground running has really been debated. And that's important because most of our runners do not enjoy just running indoors on a treadmill. So our study really aimed to compare treadmill gait analysis using that fixed video capture, which is what you've seen throughout this talk, with outdoor gait analysis using drone technology. So if you want to advance to the next slide. So our study included 32 cross-country, track and field, and recreational athletes with running mileage of approximately 15 of at least 15 kilometers per week. The study participant characteristics can be seen here on this table. Indoor running was completed on a treadmill with static video capture, similar to the images you have seen throughout the talk. Outdoor segments were obtained with a drone on an outdoor track. So we can advance next slide. So here's an example of this outdoor drone footage in the sagittal plane. And this is in somewhat of a real time, and again, having this runner run at their long distance pace. And they, as we discussed previously, also completed how about a 6-minute warm up so that their pace was acclimated, and we're getting them mid run here. And then this is an image of the same athlete indoors running in that sagittal plane. And again, these can be slowed down and paused in a still plane for analysis. And then if you want to advance here. So clinical analysis was completed on all of the footage using kinematic measurements with published acceptable intra and inter-rater reliability. So 4 in the sagittal plane, 4 in the frontal plane, different variables. And then you can advance to the next. Here's another runner outdoors in this frontal plane here being followed by drone. And then in the next slide, you can see same athlete indoors on the treadmill as that's set up. Yeah. So of the 8 kinematic variables that were measured, 2 were found to have moderate agreement indoor versus outdoor, while 6 had fair to poor agreement. Foot strike at initial contact and rear foot position at mid stance had moderate agreement indoor versus outdoor, and the remaining variables were found to have fair to poor agreement. So this really suggests that these kinematic variables may differ between natural outdoor running and traditional treadmill gait analysis. The concern with this is providing recommendations for altering a gait based on a treadmill analysis may prove to be harmful to the athlete if that treadmill analysis doesn't approximate their natural running environment on a daily basis. So drone technology may provide advancement in clinical running recommendations, capturing runners in natural environments, but we'll be doing some more research on seeing what other things may approximate outdoor running, potentially using this drone technology going forward here.
Thanks, Lindsay.
Yeah.
So, you know, the purpose of tonight's talk, we have a little bit of time for some Q&A here at the end, was really to highlight what we consider to be clinically relevant gait analysis. And I'd be happy, obviously, to share slides, or if anybody wants to email me after the presentation today, or talk in Austin if you're going to be in Austin, Texas soon, around gait analysis. But if you want to make this a part of your practice, I think it can be a really rewarding way to build a practice if you have an interest in endurance athletes and their care. And I think there's still a lot to be learned around gait analysis, as highlighted by Lindsay's portion here at the end today, in terms of what we're discovering using drone technology, for instance, in tracking outdoor running gait analysis. So I'll stop there, Nate, and happy to answer any questions.
Awesome. That was fantastic. Thank you both for sharing with us. I always learn. This is something that I share your passion. I love running and gait analysis, and I always love learning more about it. Tonight was no exception. You know, I'm going to take some of these things and start implementing with what I do. But there's, I suspect, going to be some more questions starting to roll in. Yep, and I'm seeing them already. But I am going to feed you the first question that I saw come in, which is, what are some examples of some cues you would give runners to help them improve their biomechanics? I know you said run quietly, run softly. That's a real good one. I love that one too. What others do you like to use?
So I've done mirror running, where I have a runner run in front of a mirror.
Yeah.
And sometimes whenever they're running in front of the mirror, I'll tell them that they're running over logs or roots on a trail, and to visualize that, to kind of get them to drive their knees, so that they're really, again, the focus on a lot of these techniques is to get them to shift away from rear foot striking up to a more midfoot or forefoot strike, and then change their cadence. So that's where a lot of the stuff comes. Putting a mirror in front of a treadmill, and having a runner actually visualize their cues. I know Irene Davis has done some work in this space, where she's published on her outcomes of actually gait retraining with that technique's been beneficial. So we played with that at Penn State. So there are a number of ways of doing it, but those are some real practical, easy ways to try to implement it in your clinical practice.
Cool. That's great. Yeah, I like to slow people down and work with them as they get faster. Great. Lots of comments coming in now. So this Dr. McKinney is asking 2 questions, and I'm trying to scroll without going too fast. How about a self-powered or a motorless treadmill? These curved deck woodways or true form runners. What are your comments on that?
Yeah, I've tried that. One of the people that is very innovative in that space is a regular volunteer at the Marine Corps Marathon when he's not running it.
I know who you're talking about.
Know him. So
yeah,
I have tried his treadmill. My colleagues loved watching me try to run it and self-propel it. It's actually harder, and I think you have to kind of train to be able to do it. But again, it's the same idea of changing where your foot's landing beneath your center of mass. So it's another way to do that successfully. So it fits the vein of this presentation. It's just another method to try to get people to shift from overstriding and too much forward reach and heavy, hard heel striking.
Yeah, love it. Cool. Thank you. And then his next question was about billing.
Yeah.
How do you make this profitable or fit into your business model so that you keep the lights on? And
that's a great point. So,
yeah.
So two things. I've done this. I would say I've been involved in this now for more than a decade. So I have I've assembled a fair amount of experience with this. And a lot of times now when I see a runner in clinic and I perform their static examination in the office, I look at their shoe wear pattern, I talk with them. I'll start making some adjustments right off the bat, just based on their injury history and what I've seen as a common pattern. So not everybody I see that has recurrent injuries now needs a gait analysis. I'll attempt some of this on my own before I ever get to that point. Mm-hmm. I bill as a consult new patient. They typically leave my room and they go downstairs and they have a sports PT visit right after me, where the gait analysis is performed. I then either attend if I can, or it's important that I attend, or I review later with our sports physical therapist the actual video from the gait analysis. It adds a couple more minutes to my evaluation from that day. And with time-based billing now, as of January 1st, it's the same day that I'm doing that evaluation. I can bill for that extra time I spent reviewing the video from PT. So if you do it as a and try to bill insurance as a physician for gait analysis, you will run into reimbursement challenges depending on your carrier. Then the patient will be left with a large bill and you will not get those referrals. So this is my creative way around it, where I think everybody wins. The patient has access that's covered by the traditional commercial carrier routes. I get compensated for my time and our physical therapist gets compensated for his time. So I think everybody wins in that scenario, and it's just a matter of appropriate scheduling.
It's very interesting. Yeah, I think a lot of the CPT codes are only able to be used by physical therapists. Is that right? Yeah, which is interesting.
And I know some folks do this as self-pay. And if you have a market where you can self-pay for this and you can sustain volume, awesome, good for you. I would say a lot of folks don't have markets that are like that, especially with recreational runners. And so this is a vehicle to offer this under current insurance, company rules.
Yeah. While you're on that, we're also fortunate in having a physical therapy clinic right next to ours. And how have you benefited and how have you worked, to have a physical therapist? Because it seems to me like an ideal setting. And how have you leveraged that partnership?
Yeah, so my partner's name is John. John is spectacular. His history is in ice hockey. It's not even in running, but he loves biomechanics. And I had the benefit of working with a sports PT when I was a fellow at Wake Forest, who was a previous Nike runner, and introduced me to gait analysis as a fellow. When I came to Penn State, I immediately asked our sports physical therapist, said, who's interested? This is something I want to develop here at Penn State. John expressed the interest. And that relationship has blossomed over time, that John's been a part of our research projects now, and it's been a real career fulfiller for him as well. And I think hitching in with the physical therapist was of huge benefit for me, because we both approached gait analysis from different professional identities and backgrounds, which has made for a much richer evaluation. And we've been able to tease out clinically relevant pieces to this based on the sports PT and the sports medicine literature. So that we, again, back to that earlier point, we just don't drown in lots of data that we don't know what to do with, but we really focus on the high yield stuff that's clinically relevant. So having that kind of a professional hitch to you, huge benefit. Whether they're in your practice or somebody else in the community that you develop a relationship with, there's somebody in the community, sports PT, that I work exclusively with as well with runners. Same relationship with him. It's just not as convenient as downstairs from my ortho practice. Very cool.
Yeah, that's very, I just get excited talking about this stuff. Okay, I've got a question from Jennifer Adelman. Thank you for sharing this. It's very exciting to see the advancement of wearable technology for studying gait. I completed a study with UC Davis utilizing actigraph monitors, estimating GRF. But it is exciting to hear about other options, user-friendly stuff like the Runscribe. Is Penn State working on any other studies using wearables and outdoor running situations?
We just met as a research team Monday night. We're going to start 2 new projects, and one of those 2 projects will be looking at wearables. Yes. So while the drone project was awesome, that will be published in Sports Health in an upcoming issue. It's available now to look at, but that requires an FAA license, because using a drone for research or clinical purposes is considered commercial use, not recreational use. It's not like you're flying a drone in a state park. So you have to file an FAA flight plan when you're videoing, and all sorts of restrictions around that.
Wow.
So Lindsay lived that life as part of our project, and I'm sure she's still recovering from that piece of the work. So while that's really cool to look at, and the drone technology was really allowed us to ask, I think, a really important question and try to help answer that question, it's not a practical solution, probably. We have looked at autonomous drones that will track you as an individual.
Yeah.
That's kind of a little sci-fi-ish, but that technology is probably going to get there someday. But I think the wearables are really promising and can give you the same information without videotaping the runner. And that is going to be part of our future work here at Penn State, launching this year. So yeah, great question. I'm super excited about that space as well. I share that interest with you.
Yeah, likewise. I like to use Runscribe as well. I've used Dorsiflexion also.
Awesome.
It is exciting.
You just have to make sure your runner returns it, because they're not cheap necessarily to purchase. So you have to trust your runner.
That's true. Or have to send your drone after them and
correct. Yeah.
And follow them. So, okay, another question. There were several factors that you noted that played a role in patellofemoral pain syndrome in runners. Has this translated at all in changing your evaluation or treatment algorithms for non-runners with PFPS?
That's a great question. I actually think it just has reiterated and supported my approach to patellofemoral pain syndrome and other types of athletes. So I think lunges are fantastic for business and sports medicine. I'm glad people do them because people come in, but lunges and deep knee squats and bends and leg presses, where your knees get bent beyond 90 degrees. It's a pretty common reason why people with patellofemoral pain come into my practice, at least. And so the idea of knee flexion angle, putting you in a position where your knees are bent beyond 40 degrees, fits that deep knee bend for patellofemoral pain. So I think that that's helpful to think of. The impact forces you generate when you rear foot strike are real. Many people, obviously most American runners rear foot strike. That's been shown in study after study. So again, if it's not broken, don't worry about it. But I think maybe in that way, if I have someone with patellofemoral pain and they're a running athlete, not necessarily a runner, but they're in a running sport, thinking about how they're running would be something I would consider based on my understanding on biomechanics. So yeah, I think that probably has translated across. But the deep knee bend stuff, I think in large parts just reiterated what I've already assumed to be a problem.
Yeah, for sure. I would agree with you on that. I find that we're running short on time. I could talk about this for a long time. I see a question coming in from, I think this is Jennifer again. Thank you. And she's actually thinking the same thing that I am, because I'd love to hear you talk about running shoes and how that influences gait. And that's what she's asking, basically. A big question, I know, but I think it's good for fellows to think about and understand. I know it's hard to answer this in a short amount of time, but Jennifer is saying, can you speak to your thoughts on barefoot running versus Hokas and everything in between? So I'll lob you that one.
Yeah, Lindsay's laughing because I promised her I wouldn't talk about running shoes tonight because she knew I'd go over time. So I'll try to answer this briefly. Just say that a couple things. If you have a chronic metatarsalgia, metatarsal stress fractures, Achilles tendinopathy, calf strains, barefoot minimalist runnings may not be the best thing for you based on that injury history. So we have to be thoughtful that we don't try to convert everybody over to a midfoot, forefoot strike. One way to get somebody to midfoot and forefoot strike is to give them feedback that heel striking hurts. And the best way to make heel striking hurt is to remove any type of structure support for heel striking. So you take away the cushion, the structure of the shoe, and you said Hoka in your comment, and that has a lot of cushion. You take that away, it hurts to hit your heel. So that provides some biofeedback to get people to increase their cadence and get up on their forefoot midfoot. One of the challenges, and I'll stop here, one of the challenges around barefoot or minimalist running is that as people tire, they revert back to rear foot striking. That's actually been shown in the literature. I've seen that in my personal experiences. And that's the worst thing that can happen then, because now you're heel striking with no protection. Whether you're in a minimalist shoe, a true minimalist shoe with less than 4 millimeters of heel to toe drop, or whether you're actually barefoot. So you have to be really thoughtful, I think, about that transition. It takes a long time to get your strength to the way that it needs to be to support barefoot or minimalist running for long distances. You need to be patient. Your runner needs to be patient. And you need to think about making sure you're not solving one problem by creating another. So what are the stress points when you're running your forefoot midfoot? How does that change your running gait? What tissue does that stress? And if they have recurrent issues with those tissue structures, that may not be the best solution.
Yeah. Gosh, you've done a great job summarizing these important concepts. Thank you. And I know we're getting short on time. My fellows who are on the line here know that I can go off for a long time about these topics too. So James Kelly is asking, and thank you for this question. We don't have time to talk about everything we'd like to tonight. Is there some references that you know, some good resources to learn more? In particular, James is asking about long-term outcomes in picking up some of these flaws with running. And what other resources do you like to point runners and clinicians to?
First of all, hi, James Kelly. I haven't seen you for a while. It's nice to see you tonight. I'll just say two things. One is, you know, there really isn't a lot of good data out there on sustaining running gait changes beyond 6 months. That is an area, if you're interested in this space, that's an area that should be studied. Do changing people's running biomechanics, do they get sustained over the long term? 6 months is about that, and maybe Nate, you're familiar with stuff that takes it out a lot longer than that, but 6 months is kind of at the end of what I've seen published.
Yeah, for sure.
To date. So I think that that's an open area that should be researched. Two, I referenced an article in my presentation tonight. There's a review article in Physical Medicine Rehabilitation Clinics, I think from like 2016 maybe. And it's a really, really good review article on running gait analysis. Some of my images were from that article. And that actually helped me up my game in my own clinical gait analysis. We've modified and adjusted and kind of gone our own way, but that's a really nice article to introduce you to some of these concepts. Play it back, you'll see that I'm cited early on in my presentation.
Great. That's awesome. Yeah, I would agree. There's most of the running mechanics studies are pretty short-term outcomes and few and far between. I think I remember one that was like a year, but that's really on the long end.
Yeah. I did drop my email in the chat for any, if that was a question, so that's in there now. So if anybody wants to chat afterwards.
Perfect. Yeah, that's great. We are a little over time. I think we have hit most of the questions. And some of the ones that I had written down, we've already addressed. So with that, it's been a pleasure, Matt.
Thanks, Nate.
Learned a lot. This is great. Very important stuff, and have the opportunity to influence someone's injury risk and send them back out and hopefully not come back with the same injury, but actually change their bottom line and break the cycle. Thank you for sharing with us. And Lindsay as well. Thank you.
Thanks for the invite.
Yeah, thanks for having it.
Yeah, it was a pleasure. Awesome. And I loved your paper too, I will say.
Thanks, Nate.
Yeah, well done.